I think the time has come for real-world data to really take centre stage now. It's quite interesting at BSH in the CLL session, in the myeloma session and in the MDS session. There are talks on real-world data, and previously it was all dominated by clinical trials. So I think everybody's woken up to the fact that the real-world data can be collected. We all knew that real-world data was important because that's the day-to-day practice, and we all knew that clinical trials is a very select patient population and may not be easily extrapolated to the real world. But I think the difficulty in the past has been collecting the data in an appropriate manner and getting it funded for collection as well. But the policists, I think they realise now that clinical trials have their limitations, and the regulators actually starting to realise that as well. So real-world data to support clinical trials, and particularly in longer-term follow-up of patients treated with the same drugs as there are in clinical trials, is coming of age, essentially. So what we're discussing on Wednesday is the European MDS Registry Programme, which is a collaborative initiative across most European countries and a few associated countries, of which we will be one shortly. And the idea behind it is that we collect data from 125 sites within those countries on the experience of MDS patients following diagnosis. So we start by registering patients within 3 months of a new diagnosis, and then we follow them for as long as the project will continue. So it started in 2008, so we have a maximum follow-up of 10, 11 years now, and we've got a large number of patients who've been followed for a few or several years. So it's now really coming into its own, having recruited 2,500 patients, and we're starting to generate a set of data that reflects what really happens to patients with MDS, how they're managed, and we can start to tease out how better to use the drugs that we have available. And we can also do research on a population of patients that reflects those that we see every day in the clinic, not the super fit patients and generally younger patients that we treat within clinical trials. So I think that the time has come, and we've learnt quite a few things about this patient journey. We've learnt that particular drugs to treat anemia will probably work better if we treat those patients before they start on blood transfusions, and there's other registry data to support that as well. So that's been really helpful. There's been much debate about iron chelation therapy, about removing iron in patients who have multiple transfusions. We're starting to again generate evidence that supports the benefits of iron chelation therapy. Again, there's been quite a bit of evidence generated in the past, but not with the same degree of quality data and granularity of data, as we would put it. So we're able now to generate a data set with lots of different parameters put into it, compare patients who had iron chelation therapy with those that didn't, and match them for many, many factors that weren't able to be matched in many of the other studies. And we seem to be able to demonstrate that patients who receive iron chelation therapy are living longer than those who didn't. So that's been quite valuable. It's a little bit preliminary at the moment, but it supports a lot of other evidence, and I think it's going to probably stack up quite well in the future. So that kind of thing, how to use the drugs that we use for anemia, how to remove iron, these are very important aspects that we're generating which affect the way that we manage patients now. But much more than that is happening within the project. We're gathering a lot of genomic data now. We're going back to samples on patients that were recruited earlier in the project, and going forward we're gathering genomic data on all patients that are now entered into the registry going forward, and we'll be able to correlate that with many different aspects of clinical care in a large number of patients. So that's one aspect. We're studying with colleagues in Manchester what's called a proteome. We're doing proteomics. We've been collecting serum samples on patients right from the start. So we now have a series of 7, 8, 9 serum samples collected every 6 months on single patients. that's a very powerful tool for studying the proteins in the serum. So we're hoping that will actually generate another set of factors that we can use for prognosis. So there's many examples of the things that we're doing in addition to the rather sort of fundamental practice-changing elements. So it's an exciting time for the project. So in the rest of the session, we're discussing two other aspects. One is red cell transfusion and how to do that better. And the other is what are the drugs that we're evaluating at the moment to treat anemia in MDS. So on the red cell transfusion side, Simon Stanworth, my colleague, and I have worked on a trial that we've been running over the last 2 or 3 years with colleagues in Canada and in Australia. And we've basically been trying to work out whether we can allocate patients to 2 different types of transfusion schedule, which we thought was going to be challenging. And in fact, we have managed to do that. We have allocated patients to 2 different transfusion schedules. And we see some differences in the outcome, which is very exploratory at the moment, but really quite exciting. And our Canadian colleagues are just completing their trial. We'll see if they come up with the same findings. And so we're moving on to the next phase of that shortly. And then the other session, which is in the programme on Wednesday, is relating to treatment of anemia. There's a new drug which is currently under consideration by the European Medicines Agency called luspatercept. And I'll be explaining exactly what the role of luspatercept is in these patients that are the target for that, and also an idea of the various different drugs that are coming along, 1 or 2 of which could well also be useful in treating anemia and be additional to what we've got at the moment. So I think we're covering several aspects of anemia and MDS basically throughout the session, which is quite a comprehensive one.